Pack your office, Lissy. Dr. Caldwell's voice cut through the sterile air like a scalpel. Effective immediately. My hands froze over the incident reports scattered across my desk. 23 flagged safety violations. Contamination protocols ignored. Staff shortcuts documented in meticulous detail. The fluorescent light above flickered, a maintenance issue I'd reported 6 times, another small symptom of the hospital's decay. What exactly are you saying? You're removed from the safety review committee. His smile was clinical, practiced, the same expression he wore when delivering terminal diagnoses to families. You're too paranoid for progress. No wonder patients don't prefer you. The accusation hit like ice water. I'd spent last Tuesday comforting Mrs. Chen while her husband fought off a post-surgical infection that proper protocols could have prevented. Yesterday, I'd stayed 3 hours past my shift helping the Gonzalez family understand why their daughter needed extended isolation, not because I enjoyed delivering bad news, but because someone had to care enough to explain the science behind the fear. The words hit harder than any physical blow. Patients don't prefer me? Last month, Roberto Martinez had grabbed my hand with tears in his eyes, thanking me for catching the contamination that could have killed his newborn. Maria Patterson had written a letter to administration praising my thoroughness after I'd identified the source of her recurring infections. But patient gratitude didn't appear in quarterly profit reports. This is about the isolation ward recommendations, isn't it? My voice remained steady despite the tremor in my chest. This is about creating a functional workplace environment. He adjusted his tie, silk, expensive, probably worth more than most nurses made in a week. The irony wasn't lost on me that his luxury came from the cost-cutting measures I'd opposed. Your constant fearmongering undermines staff morale and hospital efficiency ratings. My throat tightened. Fearmongering? I documented 17 preventable infections last quarter alone. The hand sanitizer placement obsession. The excessive quarantine protocols. The paranoid screening procedures that delay patient throughput. Each accusation landed like a medical examiner's findings. We need team players, not alarmists who slow down our treatment workflows and hurt our performance metrics. Behind him, through the office window, I could see the isolation ward where my policies had once protected the most vulnerable patients. Now it operated under Caldwell's streamlined procedures, faster turnover, reduced screening, minimal protective equipment to save costs. A perfect breeding ground for the disaster I'd predicted in my last report, the one sitting unread in his inbox. I stood slowly, my legs unsteady beneath the weight of 3 years' worth of dedication being dismissed as corporate inconvenience. The room tilted slightly, as if the hospital's foundation had shifted beneath my feet. The same foundation I'd worked tirelessly to strengthen while others eroded it for profit. 6 months of research sat before me in neat stacks. Peer-reviewed studies on airborne pathogen transmission. Documentation of successful outbreak prevention strategies from Johns Hopkins and Mayo Clinic. Late nights cross-referencing CDC guidelines with LifeBay's current practices, identifying gaps that could cost lives. All dismissed with corporate buzzwords and efficiency metrics. My recommendations: they could prevent the next MRSA outbreak, reduce readmission rates by 30%. Were noted and filed appropriately. His tone carried the finality of a death certificate. The board has decided to pursue more collaborative approaches to safety management. Collaborative. Translation: approaches that didn't challenge the bottom line or question administrative decisions. Filed. Not implemented, not even seriously considered, but filed in some digital graveyard where inconvenient truths went to decay alongside patient welfare. I gathered my reports with hands that shook from suppressed fury rather than fear. The isolation protocols I designed after studying outbreak patterns from 43 similar hospitals. The contamination tracking systems that could identify transmission sources within hours instead of weeks. The outbreak prevention strategies that represented not just months of research, but the crystallized experience of every preventable death I'd witnessed. Clean out your committee access codes by 5 p.m. Security will escort you out if necessary. The threat hung in the air like antiseptic fumes. I looked around the office one last time, the wall charts tracking infection rates, the reference books annotated with my handwritten notes, the photographs of patients whose lives had been saved by protocols he was now abandoning. I walked out quietly, my footsteps echoing in the empty corridor like a funeral march. Behind me, LifeBay Hospital hummed with its usual artificial efficiency, unaware that its last line of defense against invisible killers had just been severed by budget-driven ignorance. 6 days. That's how long it took for my world to crumble and reshape itself into something harder, more focused, infinitely more dangerous. I sat in my apartment, surrounded by boxes of research I'd accumulated over 3 years of fighting institutional apathy. Every late night spent analyzing infection patterns while other doctors attended dinner parties. Every weekend sacrificed to study CDC bulletins and WHO guidelines while my peers played golf with pharmaceutical reps. Every family gathering cut short by emergency calls about potential contamination risks, earning me the family nickname Dr. Doom. My sister Rebecca used to joke that I loved bacteria more than people, a comment that stung because it contained enough truth to wound. She wasn't entirely wrong, but she missed the crucial point: bacteria were predictable adversaries. They followed biological laws, reproduced according to known patterns, responded to specific treatments. They didn't lie about infection rates to improve stock prices or manipulate data to justify cost-cutting measures that endangered lives. The isolation ward had been my specialty, my kingdom of controlled chaos where LifeBay's most vulnerable patients fought microscopic battles for survival. Room 247 housed cancer patients whose immune systems couldn't handle a common cold. Room 251 sheltered premature infants whose underdeveloped lungs made every breath a victory. Room 255 protected organ transplant recipients walking the razor's edge between rejection and infection. I'd tracked every case with the obsession of a detective working a serial murder investigation, because that's exactly what healthcare-acquired infections were: serial killings by negligence. My reports read like forensic analyses, mapping transmission routes, identifying vectors, predicting outbreak patterns with the precision of an epidemiologist and the passion of someone who'd held too many dying hands. 3 years of 14-hour days that began at 5:30 a.m. with coffee strong enough to dissolve steel and ended near midnight with data analysis that painted increasingly grim pictures. 3 years of studying outbreak patterns from hospitals across 3 continents, learning from their failures, documenting their successes, building protocols that could prevent the preventable. My mother called it obsession during our weekly phone calls that grew shorter as my warnings grew more dire. You can't save everyone, Lissy. You're burning yourself out fighting windmills. My ex-boyfriend called it career suicide during the argument that ended our 2-year relationship. You're making enemies of everyone who matters. Choose your battles. They weren't wrong about either assessment, but they fundamentally misunderstood the stakes. I joined LifeBay fresh from my infectious disease residency at Emory, armed with cutting-edge knowledge and idealistic energy about transforming healthcare safety culture. The first year, I was the eager newcomer with innovative ideas that impressed senior staff during monthly meetings. The second year, I became the persistent voice raising uncomfortable questions about why our infection rates exceeded national averages. By the third year, I'd evolved into what Caldwell euphemistically called a disruptive influence whose recommendations threatened quarterly profit projections. The truth was simpler and more brutal: I'd become financially inconvenient in a system where patient outcomes were secondary to shareholder returns. My recommendations cost money that hospital administrators preferred to spend on marketing campaigns and executive bonuses. Proper isolation required additional nursing staff at $32 per hour plus benefits. Better equipment meant investing in UV sterilization systems that cost $200,000 per unit but could prevent millions in lawsuit settlements. Slower patient turnover reduced bed occupancy rates that determined quarterly performance bonuses for senior management. In a healthcare system where profit margins determined policy, safety protocols were expensive luxuries that interfered with the fundamental business model. I documented 17 near-miss incidents in the past 8 months alone, each one a canary dying in the coal mine of institutional negligence. Contaminated surgical instruments were used before proper sterilization cycles completed. Isolation procedures bypassed because cleaning rooms between patients took too much time. Staff cutting corners on hand sanitation because soap dispensers weren't refilled frequently enough to maintain adequate supplies during busy shifts. Each incident had been addressed through additional training, corporate euphemism for acknowledge, document, and ignore. The training sessions lasted 30 minutes, covered liability protection more thoroughly than actual safety procedures, and were promptly forgotten under the pressure of impossible patient loads and inadequate staffing. The morning Caldwell fired me, I'd been preparing my most comprehensive report yet, a 40-page analysis with statistical modeling that would have impressed epidemiologists at the CDC. Cross-contamination patterns suggested systemic failure cascading through multiple departments. Environmental sampling revealed bacterial colonies thriving in areas that should have been sterile. Patient admission data showed infection clusters that formed predictable patterns around staffing changes and policy modifications. Without immediate intervention, we were creating perfect storm conditions for a major outbreak that could kill dozens and destroy the hospital's reputation permanently. Now that report sat on my coffee table like an unexploded bomb, its warnings unheeded, its recommendations dismissed, its author discredited and discarded by an institution that preferred comfortable lies to uncomfortable truths. Silence became my greatest weapon, sharper than any scalpel, more precise than any diagnostic tool. I stopped calling colleagues to discuss mounting concerns about LifeBay's deteriorating safety culture. Stopped attending the quarterly medical conferences where I'd previously networked with infectious disease specialists from research hospitals. Stopped responding to worried text messages from the few remaining staff members who still respected my expertise and understood the gravity of what was unfolding. Instead, I became an observer, a shadow collecting intelligence with the patience of a seasoned investigator building an airtight case. LifeBay's public records were surprisingly detailed for anyone who understood medical coding systems and knew where to look for buried information. Patient admission patterns revealed seasonal fluctuations that correlated with staffing cuts. Length of stay statistics showed concerning trends toward premature discharges. Readmission rates hinted at underlying problems that administrators preferred to classify as unrelated incidents rather than systemic failures. All publicly available through state health department databases. All carefully sanitized to protect hospital liability. All telling a damning story if you possess the expertise to decode the medical bureaucracy's elaborate euphemisms. I created new email accounts with untraceable anonymity, prompt observer, healthcare watchdog, patient safety advocate. Anonymous social media profiles that could monitor professional discussions without triggering recognition algorithms or raising administrative suspicions. Digital personas that moved through medical forums like invisible ghosts gathering evidence. My former colleagues shared their frustrations with surprising candor on professional platforms, never suspecting that Infection Control Specialist 2024 was someone they'd worked alongside for years. Their complaints formed a consistent pattern that validated every prediction I'd made during my final months at LifeBay. Rushed discharge protocols that prioritized bed turnover over patient stability. Insufficient cleaning time between high-risk patients because housekeeping staff had been cut by 20%. Pressure from administration to maximize throughput regardless of contamination risks because efficiency ratings determined departmental budgets. Everything I'd warned against in reports that were now being proven prophetic through the bitter experience of frontline staff who lacked the authority to implement necessary changes. I began documenting everything with the methodical precision of a forensic scientist building evidence for a criminal prosecution. Screenshots of internal communications accidentally shared on social media platforms. Public health inspection reports buried in municipal databases that required specific search terms to locate. Staff scheduling patterns that revealed dangerous understaffing during critical periods when infections spread most rapidly. My apartment transformed into a command center that would have impressed intelligence analysts. Wall charts tracking infection rates across multiple facilities for comparative analysis. Timeline matrices linking administrative policy changes to patient outcome deterioration. Correlation graphs that demonstrated causal relationships between cost-cutting measures and preventable deaths. The pattern was beautiful in its predictable horror, like watching a mathematical equation solve itself through human suffering. Caldwell had restructured safety protocols 3 times in 6 months following my termination, each revision prioritizing operational speed over contamination prevention. The isolation ward, my former domain where I'd once maintained near-zero infection rates, now operated under guidelines that would have horrified any competent epidemiologist reviewing best practices. Hand hygiene requirements reduced from 20 seconds to 10 seconds to improve patient flow. Protective equipment requirements downgraded from full isolation gear to basic masks to reduce supply costs. Room sterilization time cut from 2 hours to 30 minutes between high-risk patients to maximize bed utilization rates. Each change saved money in the short term while creating exponentially greater risks that would eventually manifest as preventable deaths and massive legal liability. I started attending public hospital board meetings, sitting inconspicuously in the back row among family members and community advocates, taking careful notes while maintaining the appearance of a concerned citizen rather than a former insider with dangerous knowledge. Caldwell's quarterly presentations were masterclasses in statistical manipulation, full of improved efficiency metrics and impressive cost-saving achievements that board members applauded enthusiastically. He never mentioned infection rates, which had been steadily climbing since my removal according to data I gathered from multiple sources. Patient complaints buried in online review sites revealed growing concerns about hospital-acquired infections. Insurance company reports showed increasing claims related to post-treatment complications. State Health Department correspondence, obtained through Freedom of Information requests, documented mounting inquiries about LifeBay's safety practices. 2 weeks into my voluntary exile from institutional medicine, my LinkedIn profile received an unexpected message from Dr. Patricia Morrison at the State Health Department. She'd read several of my published research papers on hospital-acquired infection prevention and wanted to discuss potential collaboration opportunities on upcoming policy initiatives. I declined politely but professionally, citing current commitments while carefully noting her contact information for future reference. Some weapons were most effective when kept in reserve until the precise moment when deployment would achieve maximum strategic impact. The game was beginning, and I held advantages that my former colleagues couldn't imagine. The first move was almost invisible. I created a detailed anonymous tip to the State Health Department, documenting specific violations of infection control protocols at LifeBay Hospital. Not accusations, just observations. Timestamped photographs of cleaning procedures. Audio recordings of staff discussing pressure to cut corners. Documentation that would trigger a routine inspection. Dr. Morrison called 3 days later. We've received concerning information about potential protocol violations. Given your background, would you be available for consultation if we need an expert review? Of course, I replied, keeping my voice professionally neutral. I'm always willing to support patient safety initiatives. The inspection was scheduled for the following month. Plenty of time for problems to worsen. Next, I began systematically exposing the cost-cutting measures through professional channels. Anonymous posts on medical safety forums, highlighting concerning trends in hospital infection control. I never mentioned LifeBay directly, but provided enough detail that anyone in the medical community would recognize the patterns. Within 2 weeks, 3 different medical journals had received anonymous submissions documenting the correlation between reduced safety protocols and increased infection rates. The data was irrefutable because it came directly from LifeBay's own reporting systems. Caldwell's assistant had always been careless with digital security. Her laptop remained logged into the hospital's internal systems even when she left for lunch. A 5-minute conversation about my wrongful termination near the hospital cafe was enough to distract her while I photographed her screen, capturing next month's staffing schedules and budget allocations. The isolation ward was operating with 30% fewer trained staff than recommended guidelines suggested. Perfect. I started reaching out to former patients' families, not to discuss LifeBay directly, but to conduct research surveys about their hospital experiences. Families were eager to share their concerns about infection control, inadequate isolation procedures, and suspicions that their loved ones had contracted additional illnesses during their stays. Each conversation was recorded with permission, creating a growing database of first-hand accounts. The breakthrough came when I discovered Caldwell's pattern of quarterly bonus calculations. His compensation increased directly with improved efficiency metrics, shorter stays, higher bed turnover, reduced protocol compliance costs. I'd stumbled onto a financial incentive structure that rewarded dangerous practices. By month's end, I had assembled a comprehensive dossier that would destroy not just Caldwell's career, but potentially expose LifeBay to massive liability claims. Legal documentation of willful negligence. Financial records proving profit-driven decision-making that endangered patients. Statistical analysis showing increased mortality rates correlated with his policy changes. But I needed one final element to ensure maximum impact. I needed an outbreak. It started on a Tuesday morning with screaming. Code Silver. Isolation ward. Multiple patients in respiratory distress. The emergency alert echoed through LifeBay's corridors as I sat in the parking lot, listening to scanner traffic from my car. 47 patients had developed identical symptoms overnight. Respiratory infection. High fever. Rapid deterioration. By noon, the CDC had been contacted. By evening, the media had arrived. Outbreak at local hospital raises questions about safety protocols dominated the evening news. Reporters interviewed families whose loved ones had contracted the mysterious illness. Public health officials promised thorough investigations. Caldwell appeared at a hastily organized press conference, his usual confidence replaced by barely controlled panic. "We're cooperating fully with health authorities. Patient safety remains our top priority." The state health department's investigation team arrived the next morning. Dr. Morrison led the inspection, armed with anonymous tips that guided them to exactly the right violations. Contaminated equipment. Inadequate isolation procedures. Staff shortcuts that had created perfect transmission conditions. Within hours, they discovered what I'd predicted 6 months earlier: systemic failures in infection control that made outbreaks inevitable. The lawsuit announcements began on day 3. 12 law firms representing 43 families filed claims alleging negligent infection control. Each filing cited identical evidence, documented protocol violations, understaffing records, and financial incentives that prioritized profits over safety. Caldwell's assistant called in sick on day 4. Her replacement accidentally forwarded internal emails to the wrong recipients, emails discussing how to minimize liability exposure and deflect blame for the outbreak. Local news outlets received copies within hours. The medical board launched its own investigation on day 5. Caldwell's license was suspended pending review. 3 other administrators were placed on leave. The isolation ward was closed indefinitely. By week's end, LifeBay's parent corporation had hired a crisis management firm and begun settlement negotiations. Stock prices plummeted 37%. The hospital's accreditation was under review. Insurance companies started canceling coverage. I watched it all unfold from my apartment, tracking each development with the satisfaction of a chess master watching an opponent realize they'd been outmaneuvered from the very first move. The outbreak had been entirely predictable. The contamination patterns matched every scenario I'd modeled in my reports. The transmission routes followed exactly the paths I'd identified in my unheeded warnings. I hadn't caused the outbreak. I'd simply documented the conditions that made it inevitable, then ensured that documentation reached people who could act on it. The call came on a Friday morning, exactly 3 weeks after the outbreak began. "Dr. James? This is Patricia Morrison from the State Health Department. We'd like to offer you a position as Chief Infection Control Consultant for our Hospital Oversight Division." I set down my coffee, savoring the moment. That sounds interesting. What would the role involve? Developing new safety protocols for high-risk facilities. Conducting compliance investigations. Preventing exactly the kind of outbreak that occurred at LifeBay. The irony was perfect. They wanted to hire me to prevent the very disaster I'd orchestrated. "I'd be honored to contribute to patient safety initiatives," I replied. "When would you like me to start?" 6 months later, I published my first paper in the New England Journal of Medicine, Systemic Failures in Hospital Infection Control, a case study in preventable outbreaks. The LifeBay incident provided compelling evidence for every recommendation I'd been making for years. Caldwell never worked in healthcare administration again. His medical license was permanently revoked. The last I heard, he was selling insurance in a small town 3 states away. LifeBay settled the lawsuits for $47 million. The hospital was sold to a non-profit organization that implemented the most stringent infection control protocols in the state. My protocols. I kept the termination letter framed in my new office, right next to my state health department credentials. A reminder that being called too paranoid for progress had been the highest compliment of my career. Sometimes the best revenge is simply being proven right when lives depend on it. The new position paid twice my hospital salary and came with the authority to shut down any facility that endangered patients through negligent safety practices. I'd gone from being an inconvenient voice to being the authority that other hospitals feared. Every day, I reviewed infection control reports from across the state. Every week, I conducted surprise inspections at facilities with questionable practices. Every month, I published findings that set new standards for patient safety. The system that had tried to silence me now amplified my voice beyond anything I could have achieved at LifeBay. My expertise, once dismissed as paranoid fearmongering, was now sought after by hospitals nationwide. I'd learned that sometimes you have to let systems collapse before you can rebuild them properly. Sometimes the best way to save lives is to document exactly how they're being endangered, then wait patiently for reality to prove your point. In the end, Caldwell had been right about one thing: I was too paranoid for progress. I was exactly paranoid enough for justice.